My name is Alexander Lebedev. I am a psychiatrist and assistant professor at the Department of Clinical Neuroscience, Karolinska Institutet. I was asked to give you a lecture on psychedelics, and believe it or not, but there is a reason for that, and it's not just because all Russians are experienced with drugs and I'm the only one who happened to be around, but rather because of my past collaboration with the Imperial College Group, led by David Nutter and Robin Carhart-Harris. This collaboration resulted in two publications. One focused on neurocorrelates of ego dissolution phenomena happening during the session with psilocybin, and the second one was focused on neurobiological predictors of personality change happening after LSD sessions. So I wanted to start by saying that this work was made possible mainly thanks to my London colleagues who were kind enough to share the data with me. The Beckley Foundation, of course, that was the major funder of the project, but also thanks to my Karolinska colleagues, of course, thanks to whom it was possible to do this side project, who allowed me to work on that as a part of my employment. So I want to give you my full disclosure. I'm a member of the Scientific Advisory Board for the Swedish Network for Psychedelic Science, a non-profit organization that is hosting today's event. But I have no financial interest in that whatsoever. I do not promote recreational drug use and recommend against taking psychedelics without professional supervision. I do, however, support rational, evidence-based reasoning about psychoactive substances in general and psychedelics in particular, and think that therapeutic value and potential of classical psychedelics should be studied more extensively for a number of non-psychotic psychiatric conditions. So you may ask why I do this. So my own interest in this vein of research was triggered by a rather unfortunate situation that we have in psychiatry, where despite all efforts made and tremendous amounts of money spent in the pharma industry, up to 30% of all psychiatric disorders still exhibit some forms of treatment resistance. The situation with drug addiction is even worse. Thus, 9 out of 10 heroin addicts, for example, return to the drug of choice within 1 year after the treatment. So in the face of this devastating burden, psychiatry is indeed quickly running out of tools. Strictly speaking, there hasn't been any major advancement in the field of psychopharmacology since late 80s after the discovery of serotonin reuptake inhibitors. And this slide illustrates this pretty well by comparing a number of mechanistically distinct drugs available to treat psychiatric disorders and heart diseases in the 50s and present days. So the paper, strictly speaking, is dated by 2005, but I assure you, the situation is still more or less identical nowadays. It's not surprising, therefore, that more and more psychopharmacology experts get interested in the field and start attending the conferences on psychedelic science and psychedelic-assisted therapy, since in the early days of psychedelic research, there were very clear indications for the medical potential that is present in these substances. So this is a quick outline for today's presentation. I'm going to start with a short introduction to psychedelic drugs and what kind of interventions we call psychedelic-assisted therapy, quickly touching upon the history, definition, and classification. Then we'll embark on discussing mechanisms of action of these substances, going through different levels from molecular, cellular system, and all the way up to the behavioral mechanisms that align their action. Then we'll move on to a purely clinical part, during which we'll discuss old and ongoing clinical trials in this vein. And we'll finish off with some concluding remarks and the panel discussion. As I said, I'm really glad that there are so many people here, but unfortunately that also means that probably not everyone would be able to ask the question with the mic. We're passing by the mic, hopefully, but hopefully you'll also be able to ask the question online by following the link that we'll share with you at the end of the presentation. So please prepare your smartphones and laptops. So let's roll. The history of psychedelic use reaches back as far as the prehistoric times, and quite reliable accounts suggest that these substances have been used by humankind in the form of psychoactive fungi and plants for essentially centuries. They were mostly used for medicinal and spiritual purposes, and many historians agree that these substances, well, literally shaped our culture and religions worldwide. However, it was only the 20th century when the substances became the subject of scientific research. It happened mostly after the accidental discovery of psychoactive properties of LSD by the Swiss chemist Albert Hofmann, who five years earlier synthesized this drug out of ergot fungus alkaloids. So the day of this accidental discovery is nicely described himself in his book, LSD, My Problem Child. And if you want to know more about this historical event and know why it is called Bicycle Day, I refer you to this book. It's a very nicely written book by a brilliant scientist. So this discovery, or accidental discovery, should I say, triggered a large number of scientific studies in this vein. Some would call that this period can be called as a golden age of psychedelic research, and indeed, between 50s and 60s, more than 1,000 scientific papers were published. These drugs were tested on several thousands of patients and healthy controls, and tremendous amounts of money were spent to fund this project. However, a series of legislative acts of late 60s, early 70s effectively blocked this vein of research, and making it virtually impossible to conduct studies with these substances worldwide. And the war on drug began. Here you can see some of its casualties, as illustrated in this almost 40 years hiatus. So during this period, almost nothing has been conducted in the vein of psychedelic research, with few exceptions. And most of the publications that were available during that period mostly used the data from the past pre-prohibition era. And it's only relatively recently when modern researchers started to re-examine the medical value and potential of these substances. This happened mostly thanks to the most brave of us, who were not afraid to put their careers at risk at the earliest days of this psychedelic renaissance. Fortunately, nowadays, this vein of research is less controversial, should I say, so it's becoming more mainstream, and more institutions and research groups get interested into this. But it was not always like that, unfortunately. And that's what brought me here to discuss this with the Swedish academia, whether there is a genuine interest present in Swedish academia and this field. And that was a really short and densely packed historical overview. Preparing that felt a little bit like preparing full-on course on human anatomy, squeezing it into a 5-minute pep talk. So if you want to know more about the historical accounts of psychedelic research, I refer you to 2 books. If you're more interested in medical application, it's probably a book by Stan Grove, LSD Therapy. It covers historical aspects of how LSD was used in a clinical setting. Some people would also recommend a new book by Michael Pollan, How to Change Your Mind. I'm currently reading it. I haven't gotten yet to the neuroscientific part, but I can clearly recommend it because it has an amazing historical overview of the psychedelic research. So anyhow, let's dive into psychopharmacology. So by psychedelics, we understand a family of psychoactive substances whose primary action is to alter cognition in a profound way, inducing a number of interesting phenomena like illusions and hallucinations. That's why the substances are also called hallucinogens. I should say that this is a rather broad family of psychoactive substances, here at least only the best known ones. For example, LSD being a typical example, a semisynthetic lysergamide, DMT, an active component of the Amazonian hallucinogenic brew ayahuasca, and psilocybin, an active component of magic mushrooms. So both are typical examples of tryptamines. Another class is phenethylamines, or phenethylamines, as some may call it. A typical example is mescaline, an active compound of some hallucinogenic cacti like peyote. But I should say that this is a much broader family of drugs, and it has a lot of different semi-synthetic, synthetic, and naturally occurring substances of this kind. So the drugs that are presented here are the so-called classical psychedelics. That means that they act primarily as serotonin receptors, and you don't need to be a chemist to spot a similarity between their molecular structures to the one of serotonin. And one particular receptor type is of great importance. First of all, they act as agonists, or they excite serotonin receptors. And one receptor type seems to be involved in the vast majority of psychoactive properties of these substances. We are talking about 2A serotonin receptors. We know that affinity or stickiness towards this particular receptor type correlates very highly with drugs' potency. And we know quite a bit about this receptor. First of all, it's a cortical one, densely distributed in the deep layers of the neocortex, most recently developed part of the brain. It's metabotropic, meaning that it mostly alters cellular metabolism instead of acting at ion channels. And it's particularly widely distributed in the high-order networks that we know are important for higher cognition. And that's indeed where we tend to see changes in the brain dynamics induced by these substances, like on this slide showing psilocybin-induced reductions in cerebral blood flow with arterial spin labeling. Interestingly, many of the structures are the so-called hub nodes, meaning that they integrate information from different sensory modalities. Shutting them down leads to global change in brain dynamics, and this induces a number of interesting states that are unique for psychedelic conditions. Thus, some networks that normally do not interact or interact very little start cross-talking a lot more with each other, and people start observing interesting phenomena like synesthesia, when you, for example, can see music. Also, interestingly, this ability of psychedelics to induce highly disorganized and fluid states of brain dynamics seem to underlie their therapeutic action. So thus it has been shown that the depressed state is characterized by a very rigid pattern of brain dynamics. So the number of hidden states that the brain can be in a depressed state is very narrow. So the brain looks trapped into the suboptimal states of brain dynamics. And what psychedelics do, they induce the opposite states of the ones seen in the depression. So it enhances, the classical psychedelics seem to enhance the repertoire on the number of possible states that the brain can be, so making the brain dynamics more unpredictable, more fluent, more, if you will, randomly wired. So, but before we actually embark on discussing clinical application of psychedelics, I'd like to drop some facts. I call them surprising because they still surprise many people, and unfortunately even those who work, or at least some of those who work in the mental health care. So many people still believe that these substances are dangerous because, well, they're addictive. There are no evidences for habit-forming effects of these substances, just to be clear. Some would even call them anti-addictive, and in fact, the vast majority of people try them, or if trying, they try it once or a few times and never do it again. Also, these substances tend to have very low profile of biological toxicity, and some would call them one of the least toxic psychoactive substances. A common way to measure that is to estimate a ratio between lethal dose and effective dose. So essentially, to put it in simple words, how big is the difference between the dose that would induce the effects that you're after compared to the one that would normally kill you. And for LSD, this ratio is estimated at 1,500. So making it virtually impossible to die from LSD poisoning. To give you more intuition into this, I should say that for caffeine, probably something that you had this morning or maybe before the lecture, this ratio is about 60 or 70, and for alcohol it's 10. Again, despite public concerns, to date we have no evidences that psychedelics induce schizophrenia spectrum disorders, even though mostly we have information from populational studies, which provide limited evidences, but at least they do not support this idea that psychedelics produce states and trigger schizophrenia spectrum disorders. In contrast, all virtually populational studies suggest the opposite. Thus, the history of psychedelic use has been shown to be associated with reduced suicidality, psychological distress, and criminal behavior. When administered in a controlled and safe setting, these substances seem to produce experiences of deep personal significance and may even have positive effects on well-being and life satisfaction. And if administered in a clinical setting, can have positive effects on a number of non-psychotic psychiatric disorders. We are talking mostly about mood disorders, anxiety disorders, trauma-related problems, but also addictions and some other conditions like cluster headaches, but that's a different story. Finally, there are clear evidences that these substances enhance plasticity or ability for the brain for long-lasting changes, and as well as learning. And these particular effects have been reliably demonstrated. Thus, it has been shown that even a single administration of a psychedelic, in this case LSD, produces immediate increases in expression of plasticity markers, like in this case CFOS and ARC, both are known markers of plasticity important for memory and learning. And CFOS is a transcription factor important for self-differentiation and proliferation, whereas ARC, or activity-regulated cytoskeleton-associated protein, is important for dendritic pruning or formation of new connections in the brain, roughly speaking. So these effects of psychedelics have recently been proven again, and in this paper that literally got published recently this summer. So in a series of in vivo and in vitro experiments, these plasticity-enhancing properties of classical psychedelics have been demonstrated, and even a mechanism has been proposed. So if you want to know more, I refer you to this paper. An interesting review conducted by Harvey quite some years ago looked into the vast majority of available 2A agonists, and just reminding you that those are virtually all classical psychedelics. And what they found was quite interesting, that 2A agonists enhance learning in animal models in the doses that are equivalent to hallucinogenic in humans. So it seems like there is something interesting and special about these substances and these receptor types, since their activation seemed to produce lasting changes and enhance sensitivity of the individual or the organisms to environmental changes. So a paper published last year from the Imperial College group attempted to summarize what I've just presented you and proposed a bivariate model of brain serotonin function, proposing to differentiate between two largest families of serotonin receptor. The 1A family, mostly targeted by modern SSRIs, was proposed to be associated with passive coping of stress, which in turn is linked to enhancing resilience, patience, and ability to tolerate larger amounts of stress. Whereas the 2A family, targeted by classical psychedelics, has been linked to active coping with stress, which in turn has been linked to enhanced plasticity, environmental sensitivity, and ability to learn and relearn depending on the changing environment. So these plasticity-enhancing properties of psychedelics provide one of the rationales for the use as adjuncts in psychotherapeutic process. Historically, two conceptual models have been proposed. The first one is the psycholytic, where entheogen-enhanced psychoanalysis was developed mostly in Europe, and it entailed multiple low-dose sessions aimed at enhancing standard psychotherapeutic interventions, usually conducted in a classical psychoanalytic context. Another model was mostly developed in the United States, and it's called psychedelic, and it entailed one of few high-dose sessions to induce the so-called mystical type experiences or moments of intense catharsis. These phenomena have been extensively studied by Walter Pahnke in the 60s. By analyzing a large number of psychedelic sessions, he noted remarkable similarities between high-dose sessions that people had, and he noted that many of them reported the so-called phenomenon of ego dissolution when they lost the sense of self, when the boundaries between themselves and external reality get dissolved. So that they reported that the concepts like time and space and the self disappeared for them. They felt deeply positive mood and the sense of awe, and they reported that the experiences that they had very high personal significance. And interestingly, it was also difficult to put the experiences into words. So some said that the experiences that they had are in the pre-linguistic domain. There are no words to describe these experiences. So these phenomena are currently under investigation or being extensively studied by the Johns Hopkins group. The first modern study from this group was published in 2006 and was focused on people who had very little to none experience with classical psychedelics. So they organized a single session with psilocybin, reminding you it's an active compound of magic mushroom. So that was one high-dose session. And after that session, almost two-thirds of all volunteers reported their experience as either single most meaningful experience of their life or among the top 5 most meaningful experiences. So this study was followed by a number of other projects, and one that I find particularly interesting is the one published in 2011 from the same group, first authored by Catherine McLean. Before I talk about the study, I should say that once you reach your 30s, I don't know how many people are in 30s here, but once you reach 30s, your personality traits are relatively stable, and there are very few things that can actually change them. And personality trait openness is among the most stable ones. And it's an interesting one. So it's one of the big 5 personality traits, and it has been linked to a number of positive aspects of human behavior, like creativity, psychological well-being, but also ability to enjoy social interactions, ability to enjoy art, and so on. So what is important is that it's one of the most stable personality traits. But what has been shown in this study, that even a single session with psychedelic called psilocybin, the same drug as in the previous study, is able to produce prominent increases in this personality trait. And remarkably, that those who had the so-called mystical type experiences that I talked a moment ago about, they tended to develop changes that were particularly enduring and were still significant 1 year after the session and perhaps even longer. So this effect on personality trait openness was replicated in the Imperial group study with LSD. So in addition to showing that LSD can induce permanent changes in openness, we were also able to predict these lasting changes by looking into the acute patterns of brain dynamics with fMRI. So what we showed was that those people who had the most unpredictable patterns of brain dynamics induced by LSD were more likely to become more open or scored higher on openness 2 weeks later. So it was a very strong effect, significant even at the whole neocortical level. So we just talked about these seemingly positive effects on psychological well-being, and I told that personality trait openness has been linked to psychological well-being. But the question is, surely as someone might have thought about it and perhaps conducted some of the studies, at least when the substances were legal. The studies were indeed conducted in the pre-prohibition era, and one of the first meta-analyses that attempted to summarize them is coming from the Norwegian group. So first thing that they noted when collecting data for this meta-analysis was that the studies, or the vast majority of studies, are of relatively bad quality. So quite often the studies didn't have proper control groups, so the assignment was often not random. But however, they did manage to find some studies that would meet our current gold standard criteria of how a clinical trial should be conducted. And they indeed demonstrated that LSD-assisted therapy resulted in superior effects compared to a different control intervention. That's another limitation of the meta-analysis. But anyhow, there were clear evidences for its efficacy virtually across all follow-ups. Another study was a systematic review that attempted to summarize the past use of psychedelics in the treatment of unipolar depression. Again, the authors acknowledged that the quality or overall quality of the studies was rather poor. Again, the same reasons: non-random group assignment, very different groups of patients, sometimes not very representative, but still they suggested that there is an urgent need to reevaluate the efficacy of these substances in modern clinical trials, since they were, despite all these limitations, there were clear evidences for efficacy of these substances. So before actually discussing modern studies, it's important to look into the populational data. Why? Because an important aspect of evaluating whether or not a particular intervention or particular approach can be considered as evidence-based, an important aspect of that is to do a risk-benefit assessment. So, and populational studies do provide quite nice evidences about potential risks associated with certain conditions and drugs. So one of the first studies targeted a fairly large population and found no significant associations between lifetime use of any psychedelics. Rather, in several cases, between the use of psychedelics and a number of related mental health problems. Rather, in several cases, psychedelic use was associated with lower rate of mental health problems. 2015 study sample, 190,000 people. Lifetime classic psychedelic use was associated with lower or significantly reduced odds of psychological distress, suicidal thinking, planning, and attempts. Whereas it's also important to keep in mind that illicit use of other drugs, like, for example, crystal meth, was largely associated with an increased likelihood of these outcomes. So finally, more recent study targeted a sample of 766 women from marginalized social groups, reported, again, 60% reduced hazard for suicidality. Now, it is important to keep in mind that these populational studies do not provide evidences for efficacy of these substances in the treatment of these conditions, and any evidences for the protective effects against, for example, suicide, because the causal link is unclear. However, they do testify to the absence of major risk factors associated with the use of the substances, especially given the fact that for other drugs, for example, in the first two studies, this link has been demonstrated, these negative associations have been reported. And we are talking about drugs like crystal meth and alcohol. One of the most commonly discussed condition or diagnosis when it comes to discussions about safety of psychedelic substances is the so-called prolonged trip, or hallucinogen persistent perception disorder, or HPPD in short. In ICD, it is defined as long-lasting condition that is characterized by spontaneous recurrence of perceptual disturbances reminiscent of acute hallucinogenic intoxication. We know quite little about that, except for that it is an extremely rare condition. I have never met a single HPPD case that would meet strict criteria for HPPD. My more experienced colleague from London, who is closely involved in psychedelic research, says that, well, essentially all cases that he had with alleged HPPD have had clear psychiatric premorbid conditions, usually with some severe anxiety problems. And that's what seemed to correspond with the literature. And some authors indeed question autonomy of this nosology. Again, the causes and mechanisms are yet not clear. Most of the major source of the information that we have about HPPD is internet polls, which of course have very limited reliability and own biases. So, for example, people who are suffering from a particular condition are more likely to take a corresponding poll. But nevertheless, they do present a number of alleged or potential risk factors associated, increasing likelihood of this condition. So those are personal or immediate family history of psychosis spectrum disorders, uncontrolled setting, very large doses, combination with other psychoactive substances, and intake of novel psychoactive substances. And that's a different issue, another consequence of the war on drugs that probably we won't have time to discuss in details. But that's a big issue, the so-called novel psychoactive substances that people take that are that we know very little about. But again, I'm not saying that this condition is non-existent. The Facebook HPPD support community has almost 2,000 members, and it's constantly growing. So hopefully we'll soon more about that. But for now, we have very limited amount of information about that. So now let's try to put together the ideas of, well, what kind of intervention is supposed to be called an evidence-based practice or evidence-based approach. So international guidelines were originally proposed by Psychiatry in 2002, and Swedish guidelines, Vetenskaplig beprövad erfarenhet, or VBE in short, they are actually aligned, or they're supposed to be aligned with the international guidelines. And there are three major components: patient values and preferences, clinical expertise, and best research evidence as available to date. Unpacking the latter, the authors propose to differentiate the quality of different studies that vary depending on the how rigorous a particular evidence that they provide and likelihood of biases and systematic errors. So you see that meta-analyses are on top, But those of you who follow discussions, for example, on efficacy of antidepressants know that this, unfortunately, is not always the case. So meta-analyses are not free of biases and sometimes systematic errors. So that's something that is important to keep in mind. But anyhow, if you attempt to apply this criteria for a psychedelic-assisted therapy, I mean, quite often patients have preferences towards this intervention. In fact, I haven't been practicing for a while, but I still quite often receive requests from patients, you know, well, where can I do this intervention? Are there any places that would provide this sort of interventions for me? Of course, I have to say no, because these substances are illegal in Sweden and, you know, virtually in the vast majority of countries. So I think we do have clinical expertise. We have specialists that would be able to conduct a psychedelic-assisted therapy session. And finally, when it comes to research evidences, I mean, strictly speaking, all the studies have been conducted in the past. So from animal studies all the way up to meta-analysis I showed you just a moment ago. The only potential source for disagreement is the word best. Can we really call the studies that we have right now, published in the pre-prohibition era, as best? Well, if you're really strict and refer to the APA criteria of what kind of evidence should be called as best, they would say that in order for a medical evidence to be considered as best, at least 2 independent, large-scale clinical trials should be conducted for a particular intervention of substance. I wish we were really as rigorous when it comes to all kinds of medical interventions as we are right now when it comes to psychedelics. So we know that it's not always true. But the question is, are we getting there? This is the search that I conducted last year, and you see that by the end of 2016, we had only 4 registered clinical trials, which was not that encouraging. And I should say that if you are to launch a clinical trial, you're obligated to register a clinical trial in one of these 2 databases, clinicaltrials.gov, which is the United States database, or the EUDRCT, the European Clinical Trial Registry. So the situation was not that encouraging in 2016, I'm sorry. But now I will provide you a glimpse into the future. That's what happened in 2017. A huge spike in exponential growth, and by the end of 2017, 74 clinical trials were registered. So hopefully soon we'll have more information to be evaluated in thorough meta-analysis, and hopefully exciting times are coming for our psychedelic research community. So hopefully we'll soon know more about these interventions. You can also see that more and more major drug agencies start to support this line of research, like FDA's approval and collaboration essentially with MAPS, or major funder and supporter of psychedelic research. So they started to collaborate on phase 3 clinical trials of MDMA-assisted psychotherapy for post-traumatic stress disorder, a huge problem, particularly in the United States. And you can see that this clearly made a difference. So this spike is largely driven by MDMA studies, with psilocybin supported by Hefter Research Institute being only second. So this is the distribution by countries. So a lot of studies in the United States, again, Switzerland, Israel, Netherlands, Spain, Czech Republic, Canada, UK, Denmark, 1 registered clinical trial with ayahuasca in Brazil. And of course, there is at least 1 more color that I would like to see on this plot. But for this to happen, we would need a more open support from Swedish academia. So these are the conditions that are targeted in this clinical trial. So you see substantial overlap. So we're again mostly talking about mood and anxiety disorders, with 1 exception for MDMA that is almost exclusively used in PTSD trials, and 2 cluster headaches trials with psilocybin. Some of these results have already been reported. So there is a line of research conducted on anxiety associated with life-threatening somatic diseases and advanced stage cancer. And they all report comparable effect sizes across all follow-ups, showing efficacy of the substances to overcome the existential fears and anxiety associated with these conditions. 2 small-scale clinical trials for treatment-resistant depression, one with the use of psilocybin, published by the Imperial College Group, and another one with the use of ayahuasca, Amazonian hallucinogenic brew, again, both showing equivalent effect sizes at short and long-term follow-ups. Well, of course, there are weaknesses of these studies, right? Like open label design, the absence of control, placebo control intervention. But it's important to keep in mind that those are treatment-resistant patients with depression for whom traditional methods of treatment didn't work. And, well, that's a separate story that deserves perhaps a separate lecture of how to conduct a placebo-controlled clinical trial with psychedelics. I mean, it's obvious for everyone, for the patients and for the researchers who took psilocybin, who took just water. There are challenges. They are manageable, but it is difficult. It is challenging. But nevertheless, I think that these studies are of great importance. And again, despite all these weaknesses, they do provide substantial evidence for efficacy of these substances. Another issue is that the samples that are quite small, they are not perhaps that representative of the major population of people suffering from depression. So a large-scale clinical trial is needed to kind of make sure that we can observe similar or close to similar effect sizes in the representative population of people with depression. And it seems like we are getting there. World's first large-scale clinical trial with psilocybin for treatment-resistant depression has recently been launched by Compass Pathways and Worldwide Clinical Trials this summer, according to their website. It's a phase 2 dose-ranging clinical trial. So the target sample is over 200 subjects. It is a multi-center clinical trial with several clinical centers in the Netherlands and the UK. And if successful, those who run a clinical trial would embark on the phase 3 clinical trial, which is like the final milestone before the implementation of a particular approach or drug into the clinical practice. So attempting to answer today's question, are we there yet to call a psychedelic-assisted therapy a top-notch evidence-based practice? I will probably have to say that no. Because the standards of the way we evaluate these kinds of interventions have changed dramatically. Again, it is important to say that there are many working approaches in the medicine that I would say do not meet this criteria either. And we have to keep that in mind. So the question is, what should we do about that? Should we sit and wait until the results of large-scale clinical trials become available? How about most desperate cases when nothing really works for the subjects? How about compassionate use program that is specifically designed for these desperate cases, and it is applicable in Sweden as well? I mean, these are very important ethical and medical questions that have to be answered, and I really want you to think thoroughly and seriously about these questions and perhaps bring them during the panel board discussion. But before you do that, I'd like to tell you a short and personal story. As a medical student, I was involved in a rather difficult part of research, or line of research, difficult both technically and ethically. The study I was assisting on was focused on neurosurgical interventions for treatment-resistant psychiatric disorders. You may ask yourself, what does it all have to do with today's topic? I'll try to explain myself. This patient that you see in front of you, let's call him Michael, was one of the first in this study to undergo a deep brain stimulation procedure for his treatment-resistant obsessive-compulsive disorder and comorbid depression. Smart, with nearly completed PhD, which he unfortunately could not continue due to his condition. Brutal rituals and impulsive behavior. Actually, the reason why you see him wearing these white gloves made of bandages is because the moment he saw his own fingernails, he had an immediate impulse to rip them off. Multiple lines of pharmacological treatment, psychotherapy, electroconvulsive therapy, even insulin comas, nothing really worked. Abandoned, on the edge of suicide. Well, luckily for him, the government decides to sponsor a deep brain stimulation study, an intervention that eventually helped him. And for those of you who don't know, it's a highly invasive procedure that entails implantation of metal electrodes into the deep brain structures. That's the intervention that worked for him. Now, of course, this approach, this technique is based on many years of animal research, of many years of similar studies conducted in neurological populations, for example, with Parkinson's disease. But it has never been and may never become a commonly used evidence-based clinical practice. And believe me that no one in the team that I was a part of was certain that this intervention was going to work for Michael. But it did. He was helped because someone cared. Because we didn't have the war on brain surgery. The war that would put careers at risk. The war that would kill thousands simply by prohibiting science to test and decide what does and does not have medical value. Coincidentally, today is a very special historical date for Sweden. A day when many years ago Sweden did make a difference. 1631, September the 17th, Sweden wins the Battle of Breitenfeld, a major turning point in the 30 Years' War, one of the most devastating conflicts in human history. The Swedes were led personally by King Gustavus Adolphus, a tactical genius, one of the greatest military commanders of all time. He died on the battlefield 1 year later, never being able to see the end of this devastating war, to which he referred to not as a river or a lake, but an ocean of all that is evil. With these words and a hope that our 40 years war on drugs will ultimately come to its logical end, I'd like to finish my talk, and thank you very much for your attention.
Thank you, Alexander. Very interesting talk. My name is Jonas Mattsson. I'm the editor-in-chief of this monthly magazine, Modern Psychology. And we've written about psychedelic psychotherapy a couple of times. And for this panel, I'd like to invite to the stage Predrag Petrovic. You're a psychiatrist and researcher here at Karolinska. And you've studied the mechanism underlying placebo effects, as well as more general about how our perceptions is formed by expectations amongst psychosis-prone persons, among other things. And also I'd like to invite to the stage also Nilsonne, Professor Emeritus in Medical Psychology here at Karolinska Institutet, and psychiatrist and psychologist, writer, and introducer of the dialectical behavioral therapy, a mindfulness-based therapy. And you've also written a lot in our magazine. You're a columnist there, and you've written about, you did the cover story for this issue, psychosis, psychedelics, and mindfulness. And also I'd like to invite Andreas Åberg, specialist physician in psychiatry at Sundsvall Hospital. And you have a special interest in MDMA in treatments of post-traumatic stress disorder. Let's sit down here. You can grab one chair each. And maybe we can't move this microphone. You'll have to, two of you will have to share microphones. So as a start, Alexander, you said you answered the question in this today's talk. The headline: "Are we there yet? Psychedelic-assisted therapy as an evidence-based approach." But you said no. I'd like to ask you in the panel what your answer is. Yes or no, Predrag?
No.
No.
Not yet.
Åsa?
I agree with the previous two.
Yeah, and Andreas?
Can you hear me? Yes, I agree with the previous two speakers.
The same here.
Yeah, and why? Why aren't we there yet?
Well, the evidence is still quite limited. I mean,
Yeah.
The sample sizes are quite low, and but it's really promising studies. And it depends on what substance we're talking about too, and what.
Is there a difference between, for example, LSD and MDMA or psilocybin?
Yeah, there's huge differences between the. I mean, if you talk in psychedelic psychopharmacology in a wider sense, and include the ketamine and other substances like ayahuasca, and there's a quite variety of different effects and treatments for different psychiatric conditions. So it depends on that and about what country we're talking about.
Mm-hmm.
What Alexander said last in his lecture about the difficulty of even doing any research that completely wipes out the possibility of answering yes on that question.
Yeah.
So I have a thought about the historical studies also.
Yeah.
Because the diagnosis and classification of depression has been a subject on which people have had very, very differing ideas and opinions. And so if you go to the historical samples, very likely the people who were being treated and examined were not the same in different locations, and probably are not the same as the people that we would diagnose as being depressed today.
Yeah. And Predrag, what would you say?
Well, I mean, I think Alexander already said the important part. I mean, we are moving there, and we're moving there in an exponential way, basically what you showed in one of the last slides. But I think it's even more important for something that has been considered as illicit drugs before to have even better, higher standards than normally.
Yeah.
So I think that is very important. We still don't know if there are hidden adverse effects that some people can suffer from. We need to understand that better. So we need to have a rigorous research before we get this out to the clinics. Having said that, we know that other previously, let's say, illicit substances are today actually used in the clinics, like ketamine, for instance.
Yeah.
We have and there are coming compounds with ketamines that will be sold as normal medical drugs soon. And that has gone quite fast. So I think this can also be a thing that happens very quickly, actually, although we need to be very rigorous.
Yeah, I was thinking, in the beginning of your talk you said that you had this disclosure that you do not promote recreational use. You wouldn't see that in a lecture on HDAD medication or painkillers, would you?
No.
So why is that?
I have this slide every time I do the presentation.
Could you?
Otherwise,
Maybe you should sit here with this mic.
It's fine.
Yeah?
Yeah, that's true. I mean, every time I give a talk on psychedelics, I had the slide because just to make sure that I won't be misinterpreted about my intentions. That's true. My primary interest lies in the medical application of the substances. Yeah, because, well, it does feel a little bit odd when I do that, to be honest, because, I mean, why would anyone think that that's my main intention if I came to present and talk about their medical use?
Yeah. Is there a problem for this research that there is this popular cultural aura around these drugs?
I do think it's damaging. I think that these drugs are indeed stigmatized to a very large extent. And that's something that I think prevents many senior researchers from kind of diving into the field. Well, for example, I mean, let's take SSRIs. I mean, there are tons of clinical trials conducted with SSRIs. But how many of you know how one of the first SSRIs, fluoxetine, was called by the media? It was called the killer drug. And indeed, nowadays we know that actually the early period during the initial medications with SSRI is associated with elevated risks of suicide. And we know that people kill themselves with SSRIs. Does it mean that we should block studies with SSRIs? Well, you don't need to be an expert. You just need to go to the clinical unit and see how these drugs work in clinical populations and severe cases of depression and anxiety. My point is that imagine if someone kills him or herself in a clinical trial with a psychedelic. It's going to be a whole different story. And many people, I think, are afraid of it.
Yeah, there was a debate in Scientific American about this research when they pointed out that, well, somebody left the building during the research, and that was like a critique against the research. So it's not killing oneself. But why is it that this research has entered the mainstream a bit more now, after all these years? You can start, and then...
All right.
Yeah.
I think there are different reasons for that. My personal opinion is that, I don't know how many of you have heard about the situation with some prominent researchers in psychopharmacology in the UK. Well, long story short, David Nutt is the one of them who visited us relatively recently and gave a lecture here in Sweden. So he used to be an advisor for the governmental policy about rational approach to the classification of psychoactive substances. So essentially he got sacked for, well, in a way, presenting scientific evidence. So I think it produced a lot of resonance and a lot of backlash and response from academia, who decided to support him. So he eventually got a professorship position, and their studies with psychedelics were approved. So that was, I think, one of the major contributors to this psychedelic renaissance. And yeah, a series of studies in the early days of this century from Johns Hopkins group demonstrating seemingly positive effects on personality traits. And also, I mean, if you analyze a lot of studies conducted today, they are to a very large extent replication of old studies conducted in the pre-prohibition era, just in a more thorough and deeply thought way. So for example, we know of the Good Friday experiment, which resonates pretty well with the study from Johns Hopkins group published in 2006. But yeah, there are many reasons, and I think one of the reasons because academia fortunately still unites rational thinkers who want science to speak and not the politics.
Predrag.
I think I'd like to add to that we have a fantastic development of research field that is called cognitive neuroscience today, in which we try to understand how the brain processes information, how this leads to different types of behavior, and when this doesn't work, how this can lead to different types of psychiatric disorders. So this, I mean, talking about exponential increase, this has had exponential increase the last 20 years. We know very much, we have fantastic techniques to study brain function. And adding that knowledge to the knowledge that here you have something that can profoundly change brain function. People think, wow, we have another tool to understand brain processes. So I think that is added to this need for searching for a clinical kind of new method to help patients with the treatment-resistant depression, etc. So it's a very good, it goes hand in hand together, I think. Yeah. And I think that is why this research has such a, increased so quickly and so dramatically. And if you look at a lot of the research, we have a lot of functional imaging studies, a lot of studies on information processing and how the brain actually works that are going together with this studies on does it treat or not. So I think that is a very nice combination.
Yeah. Andreas, what do you think? Is it? Åsa, you're after Andreas.
Well, I think it's interesting to think about how we think about what people do and how they feel. Most people who take any kind of drug, whether it's a prescription drug or something they bought on the internet, do this because they want to change an emotion. They want to feel more or less of something. And recently, there's been a shift towards really trying to not talk to patients and tell them what their life is about, but actually to listen to what patients are experiencing. And a lot of the people who come to see us combine drugs like psychedelics with whatever else we're treating them with. And as long as they believe that this is going to make us angry or that it's going to make us call the police, of course they won't tell us about it. But I've had the opportunity, which has been very humbling, to follow patients over a long period of time, years, and seeing them every week. And after a while, you begin to develop trust, and they begin to tell you what they're actually taking and not taking. And I always thought it was interesting that we tend to be so judgmental when it comes to, say, psychedelics, and sort of to assume that you shouldn't be doing this, this must be bad for you. And so we want to, we sort of immediately start telling people, oh, this is dangerous and this is not good for you. And we would do the opposite with the drugs that we were prescribing. We would just look for the positives and not the negatives. But if you actually ask for the positives, if you ask, in which way did this make you feel better? How did this help you? Why did you do it again? It actually becomes very, very interesting to the clinician. And it makes you very interested in participating in studies or helping people develop studies. So I think there's a lot of information in the sort of naturalistic experiment that's going on all around us, and I think we're beginning to listen more to that, and I think that is also driving the research.
Yeah. How would your professional work change as a psychiatrist if you were allowed to use these drugs in the clinic with you work?
Well, that would be great.
Yeah, you worked with patients who have what you used to call borderline personality disorder.
Emotionally unstable.
Yeah.
They were usually very over-medicated with the sort of, I would say, this is fantastic. You don't need to buy expensive illegal drugs. You can get them safely from me and at a lower cost. Högkostnadsskyddet, fantastic.
Andreas, what is your experience from patients who use psychedelics without telling you or with telling you?
They all tell me about that.
They do?
Yes.
Yeah. And what's your experience from it? Is it?
Well, I had one or two patients with this hypersensitive, persistent perceptive disorder, Hallucinogen, HPPD. But that's basically the only time I've heard something negative about those experiences. And it's just like Alexander says, that these are substances that are non-addictive. And people who come to a psychiatric clinic and have multiple of problems often, or maybe multiple diagnoses and drug abuse, and sometimes I've heard that kind of sunshine story about dropping the drug abuse of other drugs with the help of acid, for example, LSD, and personal growth and insights that comes with these states. But that doesn't mean that much in a wider sense. We need the evidence of large-scale studies, and that's what Compass and to be able to use these substances in psychiatry, we need evidence.
Yeah.
Knowledge.
The knowledge about it. But it could be worth knowing that also Sweden, LSD and psilocybin was also used in Sweden in the 50s and 60s. And I was in contact with a man who did this at that time era, called Börje Lassenius. He was a board member of Socialstyrelsen at that time. And he was a clinician in the northern part of Sweden. And at that time they had the psilocybin and LSD in their medical cabinet, but they used it on a very unregulated, in unregulated ways, on various diagnoses, and they didn't have the experience and knowledge about it. So his opinion about it was also that it was a bit too dangerous at the time. They didn't have the safety routines and everything that we do have today.
We're talking about safety routines. I'm very curious about how do you conduct these studies when you give this person LSD, for example? What are the framework? Do you sit in a room here at Karolinska, or do you are you at home or in the?
Yeah, usually,
the setting is quite important, I guess.
Yes, of course. We are talking mostly about psychotherapeutic, or to put it in other words, healing setting. And actually, well, if you are to run a clinical trial, which you will definitely be obligated when working with the substances for the most part, you are obligated to conduct a study in a clinical setting, and I guess there are very few people who would be willing to have a trip in a hospital. For example, what was done in the Imperial College group, so they actually decorated the clinical unit or the clinical room to make it more pleasant visually and from the auditory perspective. So they decorated the room for the trip very carefully. So, for example, there wouldn't be any medical equipment that the patients were able to see. And again, it is important to keep in mind that we are not talking about, some sort of a quick infusion in the ICU bed. It's a proper, full-on psychotherapy, or at least a psychological support in combination with the substance.
Mm-hmm. And you mentioned in passing that there is an evident problem with the control groups with this kind of research. You're probably aware if you get LSD or if you drink water. So how do you handle that?
There are workarounds. So, for example, if a patient is naive to psychedelics, then there could be a drug of comparison, for example, modafinil, or some other drugs that do not induce psychedelic state but have some psychological characteristic effects that would alter cognition in some way. Another workaround is to employ a dose ranging design. So, for example, some subjects would receive a relatively low dose, whereas the other group would receive high dose.
Mm-hmm. You just talked about low dose and high dose. You also had these two methods, one with constant low dose over a longer period, and one with some instances with a high dose. That makes you think about this trend that is about microdosing right now. Mm-hmm. What are the benefits of each method?
I mean, the one?
Yeah.
Okay.
You can come in after, Predrag. Yeah.
I would separate microdosing field of research and psycholytic model of psychedelic-assisted therapy. So, strictly speaking, when we are talking about microdosing, we are talking about those doses that would not induce, that are barely noticeable. Mm-hmm. So, and that's another thing. So it's not always true. So people who claim to do microdosing, they just use low doses of psychoactive or of psychedelics. It's very hard to, for example, tell which is like the most beneficial approach for that. But you were wondering actually whether what is the best strategy for that? Can you just?
Yeah, I just was wondering which are the benefits with each method. Which is if this is going to be used in clinical practice, is one of the methods more?
Well, there are some old analysis suggesting, for example, that for some conditions it's more beneficial to use psycholytic model, and for some it's more beneficial to employ a psychedelic model. For example, if I remember correctly, one of the reviews said that, for example, for drug dependence and alcohol addiction, psychedelic model is more appropriate to induce this experiences of intense catharsis. Whereas for some, like smoldering, non-psychotic, very chronic conditions conducted in a full-on psychoanalytic sessions, a psycholytic concept, psycholytic model can be more appropriate. But I think it all boils down to to a particular group. It's the same as kind of answering the question, I mean, what is the best school of psychotherapy? I think the answer is the one that best matches the personality of a good therapist, and I think the same can be true for different models of psychedelic-assisted therapy. And the reality actually is that that a lot of therapists, and for example, if we are talking about some studies conducted in the Switzerland, they do some forms of combinations of psycholytic and psychedelic models. So it's not always either psychedelic or psycholytic, so sometimes it's a combination.
Okay, Predrag, you were going to comment on
the placebo.
The placebo,
of course.
Yeah.
So, I mean, I think these drugs are very, very interesting when it comes to the placebo response. And what we know from placebo research is that the placebo treatment effect is not a passive effect. It's not an additive effect. In many ways, it may interact with a substance, which means that we need to fully understand also how it interacts with these drugs. And we know this drug is, as Alexander showed you, these drugs are very interesting because they actually will make your brain hyper-connected. So it will go, so the different regions of the brain will connect with other regions of the brain much, much, much more than normally. And what happens afterwards is basically that it seems to land in a different composition after you've taken the drug and gone through everything. And this might have to do with that you're actually in a different state, maybe, let's say, not in a depressed state, for instance. But if this is true, it actually may also interact quite a lot with expectations, with what the setting is like, what you're told when you take the drug, etc. And it may actually be that these effects that are these aspects that are placebo aspects of a treatment may interact quite a lot with this connectivity and where you land afterwards. And this is something we actually want to test. And our hypothesis is basically that these drugs may be the placebo effect on steroids, basically. So what your predictions are super important for where you will land after you have taken the drug.
Could that also give you a placebo effect when you get the control group treatment? That's similar to a real psychedelic.
Yeah, I think that I mean there are different ways so the placebo treatment, the normal control group treatment, what they get, of course you can compare to, if you don't have any adverse or any effects that you experience from the drug, etc. But the other group will have that. You can which is a big problem, and you can have control groups where you make people experience different things, but you don't have the connectivity, for instance, you have in these types of drugs. So you can try to look at those types of placebo effects, but it's still not the same thing as understanding if manipulating expectations like you do in placebo studies when you have the drug is boosting the placebo effect. So this is a very complex issue to understand how our expectations interact with the drug that we need to consider in the future when we do this. Yeah. And actually it is very interesting, because if this is true, then actually you can even get adverse effects if you would induce adverse expectations while you were taking the drug. And we don't know that. We need to understand this better.
Yeah. Åsa, did you want to add something there? No? I was thinking about this, you're researching on psychosis-prone persons as well. And one thing that surprised me among the surprising facts here, it was that there was no connection between using psychedelics and mental illness. And there's said that it can cause or at least start a psychosis to take psychedelics. Is that a myth, or is it?
I think we don't know. I don't know what your reading is, but I think we don't know today. And this is one of the things we need to investigate better. We know, for instance, today that we are all we're all more or less prone to have a psychotic episode or psychotic symptoms. And this is what sometimes is referred to traits like delusion proneness. And in the end of that trait, we have something that is called like ultra high risk for psychosis. And those people, they're in a situation which is very risky, and something can push you over to actually get a manifest psychotic disorder.
And the psychedelics aren't that.
We don't know that today, I would say.
Okay.
We are all of those figures seems that it's not a big issue, at least. Otherwise, we would see it. I mean, we do see it for. I mean, it's very clear for amphetamine, for THC. It's very, very clear that you have a relation, and it's hard to show causality directly. There is a lot of studies indicating strong indirect causality of those drugs and psychotic disorders. However, we don't know this with these drugs, but at least it seems as it's not a big issue, otherwise we would see it already.
Yeah. Can you see any, if this is not an ethical issue, are there any other ethical issues in this research and these treatments? Åsa and Andreas, do you have any ethical concerns?
I mean, in a clinical setting, I think that we already exclude certain kind of treatments or pay attention more closely if we give psychosis-prone individuals that kind of treatment. And if psychedelic treatment would be introduced in worldwide, I'm sure that we would responsibly exclude persons, for example, with predispositions such as schizophrenia and things.
Yeah.
So it's not different from other psychopharmacological treatments.
Åsa, do you see any ethical concerns?
No, I was just thinking that for many drugs, you want to know, is this person a man, is this person a woman, does this person weigh 45 kilos or 97 kilos, and how should the dose be adjusted? Yeah. And as far as I know, Alexander, do we know if these kinds of considerations are important at all when it comes to psychedelic drugs? I mean, would it be interesting to understand more how to go about sort of hitting the optimal?
Again, I'm probably not the best person to ask because I'm not a practicing psychedelic-assisted therapist, but I did have conversation with people who are practicing in these sorts of interventions, and usually the dose is, being very thoroughly selected. For example, Peter Gasser from the Switzerland, sometimes they can run the study. They have ethical permissions to use up to, for example, 200 micrograms of LSD in their sessions, but quite often they go towards lower doses, and they usually decide during initial sessions when they test how a particular person tolerates different amounts of drugs. It's really, well, of course, we know that BMI is important for determining in general, how sensitive a particular individual can be to different kinds of drugs. But because these drugs are so potent, these criteria are not always applicable. Usually the practitioners decided by testing different doses starting from a very low one. But I just wanted to add something about ethical considerations. I once was contacted by the UK magazine, I won't call the name of that, and the journalist was particularly concerned with the fact that even a single session with classical psychedelics can change political views, and that's true. I mean, it has been shown in populational studies that people who use psychedelics, they tend to score higher on openness and lower on authoritarianism. And it has been shown in experiments from Imperial College London that especially people with depression after a single psychedelic session score higher on libertarian views, and well, it does influence that. It's really hard to find good words to answer these kinds of questions. But I mean, my point was that probably political views, well, it's not the main concern of people suffering from treatment-resistant depression. They have many more things to be worried about.
But since the trait openness is what changes the most, what role does openness play in psychiatric conditions? Is that the mechanism?
Well, the personality trait openness, despite the already mentioned association with creativity and some other positive aspects of personality, well, virtually it has very little association with psychiatric disorders. Well, at least that's what meta-analysis suggests, that that a psychiatric condition per se does not necessarily associate it with the personality trait openness. But what it has been shown to be associated with is psychological well-being, which is not necessarily linked to a particular psychiatric condition. And what is also important is that people who score higher on openness, they are more likely to seek help. They are more likely to employ constructive or active coping strategies, for instance, instead of kind of isolating themselves from the rest of the community. So they tend to seek actively a psychological and psychiatric help.
Yeah, I think you'll have to put your password here to get the image up, Alexander. Yeah. Sorry for the interruption. But what is it that is? What is the mechanism at work here compared to other pharmaceuticals? If you compare the psychedelics, what is like the main issue that changes it from that's different from traditional drugs that we use in psychiatry?
Well, Alexander already made a lecture about it.
Yeah, but if you like,
I think one thing is that it's such a profound. I mean, a lot of medical drugs that people take don't have a lot of effects, and you try to see if there's a small effect.
Yeah.
And compared to placebo, there's sometimes a little bit of an extra effect, but not much.
Yeah.
And but here, this is a very profound experience. So if this, these you are really going. Things are really happening that are on a large scale in the brain.
Yeah.
So I think that is one aspect of it. So, and compared to, I mean, we already have SSRIs that are working on the serotonin system. These drugs are also
what's the difference between them and these things?
This is so much more powerful on the SSRI, on the serotonin system.
Can I,
yeah.
I mean, the SSRIs are also not without side effects. And for example, sexual side effects can be disturbing, and other pharmacological treatments, you gain weight, you become passive, and things like that. The psychedelic substances are used only sparsely, 1 or 2 or 3 times in booster sessions. And when it comes to the studies made on alcohol use disorder in the 50s and 60s that Alexander talked about, with this meta-analysis, I mean, then they used LSD in quite high doses, and only 1 session was equivalent to the effect of taking antabus, which a person needs to go to the primary care center to take 3 times per week. So it's a more lasting effect, it's low toxicity, low side effect, but also a dramatic existential transformation, which we might be more precautious with certain patient groups.
That was a good difference you mentioned. Yeah. So, like the main difference between these groups of pharmaceuticals and what we already use. I know, Åsa, when we had some email conversations before this, and you mentioned talking about evidence, and if you compare the evidence we talk about here with the SSRI treatment evidence.
No, actually, the only point I wanted to make with that was that the question was now, do we have evidence for this? And I really think we've gone through that.
Yeah.
It's a difficult concept, and it's difficult, regardless of how many studies you conduct, it will be difficult to present results that everybody will respect. But I don't think there's much more to be said about that. Maybe somebody else has some more comments about that?
Basically, if you compare like the state of the evidence here compared to other drugs that are on the market, and how do we value the evidence for the psychedelics treatments compared to the treatments that we're happy to use already?
I think we should apply the same criteria as we do for other drugs. Well, and when it comes to SSRIs in particular, as I said, I'm not saying, I mean, as I said, you just need to go to the psychiatric unit and see how the substances work, and in really severe cases of depression and anxiety to see that, I mean, for some people, they are game changers. But indeed, and something that also mentioned that there were recent meta-analyses that came to very different conclusions about the efficacy of SSRIs for mild to moderate depression, so essentially questioning the efficacy. And I've been also following this discussion, or is it okay if I comment on that, or am I taking
no, go ahead, please.
someone's breath? And I've been following that discussion for a while as well. Speaking about the study that struck me the most was the one published in 2016 by Abraham. That's a group from Israel, and and first of all, to me, just the mere fact that we need a lot of meta-analysis clearly illustrates that there is a problem in the field, and SSRIs in particular. So essentially, what that group did, they analyzed different meta-analysis, I think like several, maybe 30 or something meta-analysis with a focus on SSRIs. And what they found, there were many interesting findings, but the one that struck me the most was that if the first author was coming from industry, then he or she was much less likely, like 22 times less likely to report a negative result. So that's worrying. I would say it's terrifying. So, and I mean, we consider meta-analysis as the top-notch evidence for scientific research, but I would say it's a problem. And well, I'm probably too conservative in that sense, but I think we should consider independent reviews, panels like Cochrane, for example.
But I think, thinking of that, we need to be concerned about our own studies on these types of drugs as well, because maybe we want too much. So we need to look for the black swan.
I was thinking about, is there a problem here that most people who do this research are very interested in this field and want the research to give results?
This is a huge problem, and we need to be aware of it, and we need to try to disprove ourselves and to be very critical to what we have done. And that is the only way to make really good research, actually. And we always need to think about that, because it's easy to kind of see the light and try to show everyone the light, but we need to do this the proper way.
Yeah, because listening to a presentation like this, you're like, well, why didn't we use this 15 years ago or 40 years ago? But what's there must be some more problem than like the drug policy. That's the problem here.
That's why I gave you my full disclosure in the beginning.
Yeah.
Well, obviously I do have my biases as well, and I keep asking this question, why on earth did we have to have this 40 years hiatus in research? Yes, certainly. I mean, there are challenges, and I'm not qualified enough to comment on how rational certain political decisions are, but what I can say from a researcher perspective is that it is a very hard task to conduct a clinical trial with Schedule I substances. We recently completed a clinical trial with a very well-established drug, L-Dopa, and it was a challenge. I mean, there were so many people involved in its preparation, and I mean, it's just terrifying to think how many things we'll have to take into account if we are to run a clinical trial with a Schedule I substance.
Yeah. What's that?
I was just going to say that I think it's very fortunate that these clinical trials are not being conducted with the help of drug companies who are going to market the drug. Because as you were saying, it's quite horrifying. I went to a dissertation recently where they looked at how drug companies had handled suicides and other adverse effects during clinical trials, and it turned out that a lot of them had been reclassified and in the end not reported in the paper. So as you said, it's quite terrifying. But there's a nice thing about the information that we can get about psychedelics, which is that I've never read a really interesting book or story about somebody who has tried SSRIs. I mean, sometimes they say, well, you know, I tried them and I felt better. But there are some fantastic descriptions about what can happen when you try LSD. And just one that I particularly remember is a person who is trying to give up smoking and suddenly realizes, you know, from the depth of their being, that whatever need I had of smoking was an illusion. I don't need this. And after that, they were able to just not smoke anymore. And there's a lot of, I think, interesting information to be found in the literature and in poetry. And do you think that is useful at all to you as a researcher in the field? I mean, do you read fiction?
I think that is very useful. I think every type of qualitative data that we get is very useful, and that is the foundation of designing quantitative studies, basically. So the gut feeling, bondförnuft, as we say in Swedish, to try to listen to someone and their own subjective experience, that is kind of the key for building more proper studies. So yes, very important.
Yeah. What is your impression of, Sweden is known for its hard drug policy, and does that, is it like even harder in Sweden compared to other countries to conduct these kinds of studies because of that? Or?
We don't know yet. We will see in a year.
We have one person in the audience who's kind of an expert on this.
Okay, let's hear.
You have a microphone, or you can come down here.
Let's see if we have a microphone here.
Predrag is an organic chemist. You can introduce yourself.
See if it works.
1, 2. 1, 2. Okay.
So maybe some of you know me or have heard about me. So the question is it more...
Can you present yourself?
Yeah, sure. My name is Predrag. I'm a medicinal chemist. I have a PhD in organic chemistry. I worked in the evil pharma for 12 or 13 years, mostly on CNS drugs, psychiatry and pain mostly. The question was, is it more difficult to conduct a trial with a Schedule I substance in Sweden?
Yeah.
Because in the US it definitely is. And I'm devoting a whole talk on this in the October, on the conference in October. But, okay, so spoiler warning. It is not more difficult to get a protocol approved in Sweden for a Schedule I substance. I've been working with cannabis, herbal cannabis for the past 2 or 3 years in Sweden. And we have license approvals for 21 patients right now.
Yeah.
And cannabis is a Schedule I substance. So from a regulatory point of view, the Swedish Medical Product Agency, Läkemedelsverket, they have no issue whatsoever if a substance is Schedule I or Schedule II, as long as you have a really good protocol. And I would say the most difficult part in conducting a clinical trial with a Schedule I drug is not the fact that it's Schedule I, absolutely not. The most difficult thing is to source the CTM, the clinical trial material. And I have some conflicts of interest here because I'm in the industry and I may be able to support some clinical trials with materials for that. So in Sweden you need when you do clinical trials with any drug, it needs to be GMP approved. And there are virtually 0 companies in the world who are willing to deliver a GMP approved Schedule 1 substances.
Yeah.
But that's going to change.
Okay, thank you.
I mean, for psilocybin, for example, would it be possible in Sweden to get the GMP?
Can you speak in the microphone, please?
Would it be possible to get the GMP approval for psilocybin? Okay. Well, the question is if it would be possible in Sweden to conduct research on psilocybin, for example, and to get that approval, the good medical practice approval.
Yeah.
Yeah, sure. So writing the protocol is quite possible. Getting an ethical approval is, well, I wouldn't say it can be done, but sourcing the actual clinical trial material, nobody is willing to supply you with GMP standard drug.
Okay.
And this is a bit fascinating because there are a number of registered trials worldwide, as Alexander has shown us today, but none of these trials, not even in the US or in the UK, they use non-GMP materials, and that is not possible in Sweden. So we have higher standards in that regard. So in order to conduct studies in Sweden, we need to figure out how to source GMP-approved batches of Schedule 1 substances.
Okay, thank you. What advice would you give to someone who is attempting to self-therapize through the use of psychedelics such as psilocybin or other drugs such as MDMA? The panel, who wants to answer? Some of you who work clinically.
So yes, I work as a psychiatrist as well. So, so I think that the way to do it is to try to present the data objectively, but we can't say that you should not. It must be up to that individual. It is still a risk. We don't know everything about the drugs, although that information will contain a lot of data also on benefits of that drug in for instance, resistant depression, treatment-resistant depression. Mm-hmm. And in that case, maybe I would take it.
Yeah, some more comments on that?
But you still have the problem that we were discussing earlier. How do you know that you get a drug that is safe?
Yeah.
And how do you know that it contains the amount of active substance that it's supposed to contain?
Yeah.
Most people who can you use the microphone? Oh, just det, sorry. Hallå?
Ta den här. Den här funkar.
I mean, most people who have prior experience in this field of psychedelics use recommendations from the internet, from like Arrowhead or other knarkkorven or something like that. The magiska molekyler. So there are good sites for that kind of in a harm reduction manner describes what dosage, how the small fungi look like that grows on the cow shit in the parks outside the hospital, and so on. So and what contraindications if you have combining drugs and things like that. But maybe it's not our role in psychiatry to recommend it quite yet.
Mm-hmm. Okay, so next question. When do you think psychedelic-assisted therapy will become available for the public in Sweden and the rest of the world? Who wants to answer? Alexander?
Well, it's very hard to answer this question because, we haven't had a phase 3 clinical trial yet. So once a phase 3 clinical trial is launched, then we can talk more seriously about that. But that being said, there are some countries where psychedelics are used, not like on a on a regular manner. For example, in the Switzerland, psychedelic-assisted therapy is used as a part of the compassionate use program for desperate cases. So I think that's something that is kind of often beyond the scope for some reasons in the medical community. So I think that's something that we should also keep in mind and perhaps take into consideration sometimes. I don't know how it works in Sweden, the compassionate use programs. I mean, are there any cases when, for example, a drug that would, or a particular approach that would not be approved as a evidence-based practice can be used as an experimental intervention, for example?
Yeah.
I mean,
okay, a short comment here.
Just press and hold until it becomes green.
Yeah, a short answer.
Yeah, sure. So I have to be a bit of a party pooper regarding compassionate use in Sweden. The Swedish Medical Product Agency, they interpret it so that compassionate use is only applicable after you have conducted a full phase 3 trial. So after a full phase 3 trial and before market introduction, then you're eligible for conducting compassionate use in Sweden. So unfortunately, that's not an option yet for psychedelics in Sweden.
Do they have specific requirements about what kind of clinical trial is needed to be conducted? Should it be phase 3 or phase 2? Because I mean, we have feasibility trials conducted.
Also, a compassionate use program has to be sponsored by the manufacturer of the drug.
Okay, thank you. Next question here. As a clinician, how important is it for you to have experimented personally with the psychedelics to treat patients if the experience is truly undescribable?
I think it's enough that we've seen the data. We don't take all medications that we are subscribing, even if they are described this fantastic way.
But maybe we should, I mean, to know the side effects at least.
I don't think you need to have had a baby in order to become an obstetrician. But I do think that you should not lie about your experiences, because this is the sort of thing that patients will ask. Yeah. And a lot of people will sort of try to dodge the question, but I think it makes better sense to say, no, you know, I don't have a personal experience, but I'm very interested in hearing about yours. How do you guys handle it? I actually don't have experience with these drugs, which is why I would have to answer like that. Also, I think, obviously, it seems that these drugs have different effects on different people, so maybe it's not even particularly relevant to think that you can generalize from yourself.
Yeah. More comments?
I just wanted to say that yeah, I mean, I agree with the comments, but the reality is that, speaking about those who work with psychedelic-assisted therapy, and they say that usually one of the first questions that they get from their patient, have you ever had an experience yourself? And I mean, if a therapist says no, then, I mean, there are good reasons to believe that probably subjects would feel themselves insecure. And at least speaking about the Switzerland group, for example, led by Petrovic, for them, I mean, it's a no-brainer that the therapists go through their own sessions with, in a psychedelic-assisted therapy.
Yeah, should clinicians take other medication as well before they prescribe it?
I don't think so, because they should be very carefully used in very specific clinical states.
Yeah.
They shouldn't be used just for trying in general. That is when I talk as a clinician. When I talk as a researcher, I'm a little bit more divided because I want to understand, and in that case, I would be tempted at least.
I mean, we're not going to have open tryout hours for ECT treatment on the clinics, just to try it out. But there was a time in not too long ago that LSD, for example, was used as a model psychosis to describe to get the further understanding for the mind of a schizophrenic. Yeah. But it's there is a lot of things to say about that too, about psychosis.
Yeah, and Åsa, you've written an article in our magazine about psychosis and mindfulness and psychedelics. What is your comment on using of the similarities between psychosis and psychedelics? And why don't just use mindfulness if you can get altered states of consciousness with that as well?
Takes much more work.
Yeah.
And it's not as obviously effective. No, I was just thinking about altered states of consciousness and how contextual our understanding is of them. If you present with the same kind of experience, for instance, of depersonalization in different contexts, it can be viewed as a sign that you are, in fact, becoming psychotic, or that you are attaining spiritual heights that you have never attained earlier, or maybe just that you've been very successful with your mushrooms. So I was thinking about, actually it was an attempt to discuss the fact that I think that we pathologize in psychiatry, and that we don't recognize spiritual emergencies, and we don't perhaps recognize that people may have taken a drug. In fact, one of the funniest, a really funny experience I had once when I was very young. I was working as a on-call physician, på en distriktsläkarstation, and this young man comes in, and he's with his mother, and the mother says, "Oh, he is so ill. He must be, taken to hospital." And he was pale, he was clammy, he really didn't look well. And when I finally got the mother out of the room, which was very difficult, turns out that this guy has a monumental hangover, and she has no idea. And so how we attribute the fact that people are not, well, how we attribute the reason that people are feeling ill or experiencing things is very important for how we handle.
Yeah. Would psychedelic drugs be beneficial for healthy individuals as well?
Who is healthy?
Yeah.
Yeah, I think that really sums it up. Yeah, I think this question really sums it up. And as we showed, there were clear beneficial effects that were shown in a series of studies conducted by Johns Hopkins University, showing seemingly positive effects on overall well-being and life satisfaction. So yeah, in principle, yes, I can see why not. I mean, and it's also, important to take into account. For some reasons, there is a, there is this point of view existing in our society that, doing something recreationally or for fun isn't necessarily bad. I mean, people drink alcohol, people smoke, and society accepts that. But when it comes to other mind-altering drugs, it's not always the case. So, but again, since these drugs are illegal, it's very hard to dive into this discussion. But strictly speaking, experimentally, the data suggests that it can produce beneficial effects on personality and well-being.
Andreas?
Well, there are some studies on, the meta-analysis from the States looking at the psychedelic drug users being lower in mental health issues and lower in alcohol and other drug use disorders. And from other populations in Brazil and ayahuasca users that actually use less, they have less alcohol use disorder, for example, which is a huge killer in Western society, and also smoking, which is so it has effects when it's in a cultural context in various populations on the planet.
May I ask a question?
Go ahead.
Not being very experienced, but the reports we hear about people who actually kill themselves or have tragic accidents, maybe the first time they try LSD, are they exaggerated, or have they overdosed, or what actually happens?
Yeah, this it happened obviously, and there some reports, but whether they exaggerated, I would say no. I mean, they are described by the media that it happened. The problem is that that many other suicide attempts happening, for example, under the influence or while people are unnecessarized, they go under the radar of media. So it's just media tends to be more focused on these cases like that. And obviously we have. And this case, well, by the way, they can happen, but if the setting is safe and if it is a therapeutic setting, then the likelihood of these events is very low.
So that might be a reason for not promoting recreational use.
Yeah, exactly. Yeah.
Well, I just wanted to add to this question in general. I mean, this was why David Nutt was sacked, because he said that the alcohol is much more dangerous, basically, and nicotine also. If you look at deaths, for instance, and I mean, he said it in a provocative way, but he was right. If you look at the statistics, it's super clear, and actually, maybe we don't know the long-term adverse effects. Maybe there are some horrible effects that we don't know about. But however, maybe the society should have traded away alcohol and instead have psilocybin.
Maybe.
In the future.
Yeah. That leads us to our final question. What do you see ahead of us in this field? If you want to start, Andreas, the future in this field, what do you see?
I hope that Predrag can get us a GMP approval for psilocybin. So I hope that we can get support from the experts to get approval to do research in Sweden on these substances, of course, and to contribute to this field, which is very promising and affects a lot of people globally. And to see how the multi-center studies, the results that Alexander showed are getting near, the results might support a more use in other countries in the psychiatric hospitals. So I'm looking forward to that, of course.
Yeah. Åsa?
Well, I always wonder about drugs. How do they affect parents? Is it a good thing to have two parents who have been influenced by psychedelics? Or could it possibly have some sort of negative effect on your ability to be an optimal parent?
Or positive.
Or positive, absolutely, or positive. And then I also wonder what the military-industrial complex is going to do about all this. Will they really allow potential soldiers to be swept up in a sort of happy, loving mindset that perhaps doesn't go very well with dropping bombs on people?
Predrag?
Well, for me personally, I think it's really interesting to understand the serotonin system in the brain and what it actually does. So it's so that's and especially in relation to other neuromodulatory systems such as the dopamine system, and it's super interesting. But I do, as a psychiatrist, also hope that we get new ways of treating people with that have very, very tough life.
Alexander?
Yeah, I entirely agree with the raised points, and I'm very much interested in understanding mechanisms underlying action of these substances in psychedelic-assisted therapy. I also look forward to the results of large-scale clinical trials, but at the same time, it's important to keep in mind that there is a large population of psychiatric patients who need our help right now. And I mean, that was the first project that I was a part of as a medical student, and it's very frustrating to work with these patients. It's, it's a very painful experience for the families, for themselves, and it's very frustrating for the researchers. So it's important to keep in mind that there is a group of very severe and very desperate psychiatric patients who need help, and we employ much more invasive experimental approaches attempting to treat these conditions, because sometimes the choice is quite simple for them, either suicide, and many of them do have some suicide attempts in their anamnesis, or just continue being resistant and suffer. So I really would like to see more experimental studies even before we get the final results of the large-scale clinical trials.
Yeah, let's look forward to that, future research in this very interesting field. Thank you, Alexander, Predrag, Åsa, and Andreas. Thank you very much.